So I was reminded of an article written by Dr. Balram Bhargav several years back. He had something called the rule of 80, and I'll come to that. He said, you should have your waist circumference at 80. You should have your heart rate below 80. You should have your diastolic blood pressure below 80. And at that time, he said you should have your LDL cholesterol less than 80. And what Dr. Jagat Narula has done is, he said 80 rakho usko, but make it 80 divided by 2. That's what you're telling. So bring it down to 40. So if you follow this rule of 80...
Maybe make it total cholesterol of 80.
So if you follow this rule and eat maybe half a diet once a day or one diet once a day, you will live long. But I think don't be martyrs. Be moderate in what you do. Eat whatever you want. Be moderate, and lead a happy life. You'll be okay. So coming back to this discussion on the nexus of heart, kidney, and pancreas, I was reminded of a book which was written by a person called Thomas Lewis in 1940s. And he said, 1940s or 1950s, he said the human body is not a single organism, but a community of interacting life forms, which really explains what we are going to discuss today. And unfortunately, when you are medical students, my first day in MBBS was on 8th August 1980, and the first class was physiology. And the chapter which was given was the cell, and they taught us the milieu interior of a cell. So we start with the cell and not with the human body. But now once you have graduated, you spent losing all your hair, you realize that it is holistic and we are allowed to think of multiple interactions, and that's what we are going to do today. So thank you everyone for being here. So in terms of this discussion, I want to keep it brief because I'm getting a lot of pressure from the organizers saying the award function should start soon and we should give some time for tea for everyone. So we will try and do it fast. So Dr. Ambuj Roy, cardiovascular disease, diabetes, and chronic kidney diseases are increasingly described as a cardiorenal metabolic continuum. How should this change the way clinicians approach screening and management of patients? What should be done? Should the paradigm of current screening processes change? We have one factor as an entry point, or we do screen for multiple diseases at the same time. What's your take on this?
Yeah, thank you for that question. So actually, what we need to do is break down the silos. For too long, we've been single organ doctors. We need to become really a systemic patient managers and not look at us as only as cardiologists or only as nephrologists, because nothing goes in isolation. Once you have cardiovascular disease, you need to screen for diabetes, you need to screen for kidney involvement. An example, I remember a cartoon shown by Professor Srinath Reddy, very often as the ending slide on hypertension management of a doctor just managing the right arm of the patient for the blood pressure and not looking at that massive central obesity he had, the alcohol binge that he was doing, the tobacco smoking, and to add to that, we should do all that. When hypertension is, we have 300 million people with hypertension in this country, and it's an excellent entry point to do an excellent systemic assessment, as you've been seeing. So we do all that. We also do look for a lipid profile in him. We also look at his HbA1c. We also look at often neglected, especially in our country, urine routine, urine microalbuminuria. So that would really help us break these silos and look as a person as a whole. And I'm also can quote a very excellent diabetes study from, if I remember, the Swedish National Registry, where they just showed, we generally have thought of diabetes being a death knell. If you read the Framingham study, in men it was 2.5 higher, 2.5, and in women 4 times higher risk of CVD events if you are diagnosed diabetes. But what they showed that if you just did 5 things in diabetes, like very much the Bolivian trial, if you managed to keep their HbA1c less than 7, LDL less than 100, no smoking, and you managed there was no microalbuminuria, you could, and a BP less than 140/90, a conservative goal, there endpoints were nearly similar to non-diabetics. And every 1 out of control to 5 out of control, the risk for events reached 5 times. So it shows an excellent exemplar of multi-system or multi-system management to reduce risk for individuals.
Right. Thank you, Dr. Roy, for bringing that out. It just actually brings back the story of 80. One other 80 that we forgot is that you should always be 80 meters away from a smoker. So I think that's an important message. Dr. Arvind, we know that most patients with diabetes or untreated patients with diabetes go on to develop kidney diseases or cardiovascular disease. But we still have our management principles of diabetes to be glucocentric. How do we change the paradigm to address hypertension, lipids, and other risk factors, which are, I won't say far more important, but as important as glucocentric approach?
Thanks, Dr. Prabhakar, and I think thanks to the organizers for having me here, and thanks to Dr. Prabhakar for having asked me to come. I think this is a question that we have been asking for quite some time. I think now there seems to be a definite change. We have been talking about renal cardiovascular approach, end organ protection. The unfortunate thing in India is, one, it's asymptomatic. I think the doctor's training has not really included cardiometabolic training. I'm sure the endocrinologists, diabetologists, dedicated physicians are taking care of the patients in a very comprehensive care. But all said and done, only 2% of the total diabetic population is probably seen by the specialists who are able to give this care. But I think it has to spread across the country. We have to have projects which can be scaled up. And that's something that I want to say here. But it is changing. Doctors have realized it. It's only that implementation has to start. But at a high level of specialists, endocrinologists, physicians, yes, it's already on for the last 2 years. And another interesting that I can tell you is use of AI and retinal images. We have been working on it. We are successful with diabetic retinopathy, age-related macular edema, and then glaucoma. But the next thing that's coming up is serially with the Jayadeva Institute. We are looking at retinal images and prediction of cardiovascular risk, retinal images and prediction of renal risk. Hopefully something should come out in the next 6 months.
Right. Thank you, Dr. Arvind. Dr. Bansal, we have several new therapies such as SGLT2 inhibitors, not so new, but we have GLP-1 agonists, and these have shown benefits across the heart, kidney, and metabolic consequences. So there are two things. One is an excitement that we have truly come to an integrated approach towards cardiovascular disease. And the other thing is a fear that we are medicalizing something which can be done by lifestyle. So what's your take on this? I mean, a lot of people have this dilemma.
Medicalizing?
Medicalizing a disease which can be managed by...
behavioral management.
Yeah.
Okay, so on one hand, so the coming of these new drugs, I mean, the multifactorial management of diabetes resulting in reduced cardiovascular disease, that we were practicing for a long time. But the whole approach actually has changed dramatically after the coming of these drugs, which can now be used by nephrologists also, cardiologists also, endocrinologists also, breaking the silos so dramatically that we now have to think, for example, a patient coming to us with mild albuminuria, with high LDL, with MASLD. Now, do I send the patient to a hepatologist separately, to a nephrologist separately, or one person manages it? That will have to change the whole way we are delivering care. So, although very evidently we have entered an era where there is a need to integrate all the care, but I don't know whether this will happen through AI, through technology, where I can maybe call people, why do I need, like the onus of going to different specialty shouldn't be on the patient anymore, because now we have drugs which can be given by me, but at what stage I would refer. So that's one part of it. Because there also there is little bit of over-medicalization, because after all, this is one person. We are saying he has one syndrome, but he goes to 4 different specialties. So that is one way of kind of letting the person go here and there. The second part of it is, I think we are probably all anyway medically affected. I mean, if you're saying obesity is so prevalent, it is a medical condition after all. So the presence of medicine is not over-medicalizing it. We already have reached there because of all the social factors. We are already reached to a point that these medicines are required by a large population of patients. So it's not that because the treatment is there, therefore it is medical. Of course, I mean, that care has to be taken that we are not giving it to the wrong people. But unfortunately, a large population has a condition, has dysfunctional adipose tissue because of sitting for so long. This whole generation, I don't know what will happen to the next generation. The sitting has increased so much, especially the kind of jobs everyone does, especially here. People are working, sitting for 10 hours, 12 hours. We are already, I mean, in a place and space and with the pollution here, I mean, when you were showing the social determinants, I was thinking we will be last in the scoring because, I mean, there are factors which seem to be not going away for anywhere for next 10 years. So unfortunately, because the upstream factors are not being taken care of, we are dealing with it after the diseases set in. We are in a place where there is over-medicalization. I agree completely.
All right. Thank you. Thank you, Dr. Bansal. Dr. Sriram, so in India, hypertension, diabetes, and obesity are rapidly increasing. But given that you have worked on women's health and you are a voice for women's health, how do we actually try and reach out to women, because their access in approaching the health systems is somewhat lower. So what can we do about it? And what do you think, how do we actually integrate and give them a package of care?
So sorry. First, thank you for inviting me. And
you can't hear me?
An honor. I have some echo, maybe because I'm recovering from a cold. Do you mind repeating that? I'm so sorry. You also had? Yeah. No. You're okay. I think it must be.
Okay. No. I was saying you worked in women's health.
Yeah.
And given the fact that we are moving away from a siloed approach of treating one risk factor, how do we integrate care, particularly for women, and improve their access to care?
Yeah.
So what are your thoughts on that?
So thank you for that question. And I must thank Professor Narula for the shout out he already gave about women and perimenopausal years. But before that, I just wanted to say that I don't see any major gaps when it comes to treatment in India. The gaps exist in all these other areas. For example, first in early detection and recognizing what leads to the to heart disease. And so therefore, you showed the interheart study and all those risk factors. That's the low-hanging fruit if we can identify. And in women particularly, for example, high-risk pregnancies they are a window to future chronic disease. For example, gestational diabetes, gestational hypertension, women having low birth weight babies, preterm deliveries. So if we can, even address these women and kind of keep them in our follow-up, our public, health system or the government system follows them only for 42 days after delivery. And after that, they're kind of, on their own to fend for themselves. So if we can in some way, marry the NCD program with at least these women, if not everyone, that would be one good way. And the second thing is, of course, to have a life course approach, which is, women, while men and women are equal but not the same. So starting from the pregnancy to postpartum, everything is actually a high risk for heart disease. So these are all opportunities for us to screen them and counsel them. And so to answer your question directly, I think from medical school level all the way up, looking at chronic disease through the gender lens. That has to be incorporated at every level. The frontline health worker upskilling, because they are the people in direct contact with, in Tamil Nadu, for example, the village health nurses. they are the ones who are called akkas, and they reach out to all the women. So if their capacity is built about this, it would be very, very helpful. And in terms of raising awareness, my dream is to have something like the Go Red in India, the Go Red for Women program, something like that, a national campaign. All of this, I think, has to be done to decrease the burden of heart disease in women, which ultimately, even though men may be having more heart disease, more women die of heart disease. Their symptoms are different. Their risk factors are different. PCOS, GDM, small babies, preterm deliveries, all of those things, early menopause. So this way we keep focusing on them at every stage.
Thank you. You brought out two very important points. One, we need a life course approach, a life course model. And second, we require advocacy. Now that brings directly a segue to ask Dr. Narula as the president of the World Heart Federation. So Dr. Narula, you would agree that combating the nexus of these three diseases, cardiovascular, kidney and metabolic diseases, is predicated on four things: non-personal policy interventions, reimagining the health system, behavior change communication, right? And advocacy approaches and human resource capacity building. So what do you think organizations like World Heart Federation can do? I'm asking this question because I'm going to take over from you and use your answer to think about what I can do.
So as a matter of fact, you almost said everything, what we really need to do in terms of advocacy.
I'm asking how.
Pardon?
How do we do it?
I mean, that is one of the very, very difficult things, to be honest with you. And how do we approach it? And that was one of the slides that I wanted to show and was not able to dilate upon that. And that was the Cardio for Cities type of an approach. How exactly? I mean, the most important thing is, can we really start collecting the data? And the best part of the country is that we have started to get significant amount of data. Probably India must be one of the best countries in terms of gathering the data, whether it is in the private sector or in the public sector, whatever it is. So having the data probably would take us to the next level. And then can we really start tailoring our approach based on that, whether it comes in terms of the policy making. There are multiple of these schemes which have already started in the country, which are very effective schemes. But the question only is that can we really start giving them the implementation guidelines? And those kind of things, I think, are more in domain of people like you who are running the CCDC or the Public Health Foundation of India and other things, where you are able to create a roadmap or the implementation guidelines. I mean, we know what we need to do. We have the knowledge, but we need to act there. So how exactly can you create them? But obviously the ownership will have to remain local, driven by the digital or the data-driven approaches to by the local owners.
So you're saying create localized contextual solutions with a global focus, because many of the solutions are global, but we need localized focus and context-specific solutions. Right. Yes, Dr.
Prabhakaran, do you allow me to ask you a question?
Me?
Yeah. See, you've been heading several organizations, as Dr. Jagat was mentioning. Now, health is basically a state-related thing in India. Now, if you have to implement something for chronic disease, especially obesity, how difficult it is to implement across India? I mean, you must have faced this. A national program for obesity management, national program for screening for lipids, national program for screening for hypertension. How difficult it would be for you to do it in India?
Not me, the government to do it, like policymakers to do it. So Otto von Bismarck in the 19th century said, two things should never be seen in public. One is making of sausages, and second, making of policy. So policy takes time, it's insidious, and you have to work with multiple stakeholders, work with them, create that framework of policy and give it to the states. The states are at varying level of, economic transition, varying levels of GDP. So they should have a basic minimum set for implementation, and they can add on, they can subtract, whatever, but that basic minimum should be there. So you could have an implementation. One of the key pieces we are missing in terms of, policy framework is the co-creation with the community. That we don't do. But I think currently there is a consultation with several communities. People put it out on the net. But again, here we are talking about educated people. We're not going to the communities and talking to them as to how we can do. The tribal communities are completely let off. So there are a lot of things that we can do, and we need to reimagine, rethink how to do it. I think we have just 30 seconds each for each one of you. I want to ask this question because we didn't touch upon this. Worldwide, South Asians and Indians, for any given body weight, have high body fat content and low muscle mass. We call that sarcopenic adiposity. Now we give these drugs, which are excellent. They will reduce fat. They're also going to reduce the muscle, which is going to be a problem. I mean, you may eliminate cardiovascular disease, you'll increase falls, people will die of falls, you'll cause some other problem. So how do we approach this in the context of the high body fat content in the population? 30-second answers from each of you.
I think as you're talking about GLP-1 agonists,
because
I mean, the point is, I think there was an article by Veer Sanghvi, and I had written a rebuttal which never saw the day of the light because he's a very important person. But the point is, he's written about GLP and how people will stop to going to gyms, and it will be like a panacea doing everything. But we have to realize all these drugs have never been exclusive. They have to be combined with lifestyle. So you cannot be just prescribing drugs and thinking that it will take care of. The first in any of these interventions have been combination of lifestyle, and this is only to aid you in the other way, because very recent the publication has shown that if you stop it and within 18 months everything is back, your HbA1Cs your weight is back, your HbA1Cs are back, and your blood pressures are back. So to make it really sustainable, pragmatic, and something which is scalable and doable, is that probably these have to be an aid, and then your body has to take off on its own with lifestyle management and routine things that we do.
Right. Dr. Bansal.
I agree. Exercise, that is the immediate solution. Like any other organ, we understand endocrinology, which started with just some glands, and now we talk about every organ being an endocrine gland. Muscle also seems to be an endocrine gland. There are secretory substances during exercise, and those are being studied. So maybe we have some pharmacotherapeutics in that direction. Secondly, I would quickly come back to the thing that when we keep on saying that Indians have a special kind of body, there is an anthropological reason and all that. I think that is where we need to work on by focusing on maternal nutrition. We have to change that narrative that Indians have this kind of body where every extra calorie will be just fat and no muscle. So maternal nutrition, I would say.
30-minute intervention, 30-second intervention. Sorry.
I think basically we have to start working on the awareness, and India being so heterogeneous, every 100 kilometers everything changes in India. I think it's awareness, and as you very rightly said, we have to stick to the diet and exercises, and for that I think behavioral change is something which is necessary. So we need to really see how we can work on that, because Indians are foodies, we all are foodies, and medication will definitely come into effect along with the basic diet and exercises. But I think it's awareness and the impact of obesity, cardiovascular disease on the health. I think it is something that we'll have to be talking about with every patient.
Recently, Professor Donna Ryan from New Orleans was here, and her concluding slide was GLP analogs are serious drugs and they have to be taken seriously and used carefully. And I agree, because as an endocrinologist, I'm also concerned about osteoporosis. And there's a recent study with muscle loss, you can also have bone loss. They're directly connected. There's a recent study from Sweden, I think, that has shown an increased risk of fractures. So the frailty that was mentioned by Professor Kunti this morning, combined with the muscle loss, might also predispose them to this. So just a word of caution, and just if we can correctly, choose the right person for the drug and not as a panacea.
Thank you. We're completely running out of time. 30 seconds for you, Dr. Narula. You want to say anything?
So the way, obviously what Ambuj said, I think that's the best response here, that we really need to have the behavioral changes also simultaneously, because only the drugs are not going to be working. The second important thing, as Dr. Sriram just said, I think we really need more data in terms of, we just cannot base on the small studies, like statins cause memory loss, statins cause this, statin cause. Statins have been the best thing which has happened to the mankind. Right? And we basically have been somehow or the other giving it a bad name. Similarly, is the GLP-1 also the way we are talking about the muscle loss and then the skeletal loss and all, based on some smaller studies. For example, there was a time when they started saying about the statins with the hemorrhagic stroke associated with that, and I know that you would not agree with it, specifically when we started to do the larger meta-analyses and all those things. So I think we have got to be careful about that. Also, nobody has still proven that the loss of the muscle, is it because of the sarcomeric loss, or is it because of the intracellular or interstitial fat loss associated with the GLP. So I think we have to be careful about being afraid of using the, which I call as the physiologic drugs, rather than the drugs which are messing up with your metabolism. They are bringing your metabolism back to where it should be. Rather than, so when it comes to the PCSK9 inhibitors, I prefer it to the statins, because statins are messing with the metabolism while PCSK9 is not. So question is that we have to be more careful, but the way to win the battle would obviously be both the medical support to the behavioral change rather than the other way around.
Thank you, Dr. Narula. Your message is well taken. I think I'll take 30 seconds to summarize and convey what we have learned. First thing is, what I have learned is work hard for your lunch. So do increase your physical activity, number one, which is very important. Number two is, where necessary, give the drugs, but choose your patients wisely in terms of giving those drugs. Number three is, policy matters, and we need to look at how we can implement those policies in terms of reducing the cardiovascular disease burden across the country, or any chronic disease burden. So that's number three. Number four, the communities and communication are very important, and we also need to look at vulnerable population. Number five, we didn't talk about the elephant in the room because of paucity of time. You showed one on the indoor air pollution, but we also have ambient air pollution. That's for another day, because we're totally run out of time. But I think this was an excellent discussion in terms of what we can do for CKM. And the final point is that science is reductionist, but our solutions have to be holistic. So the patient is a whole. He or she is not part of multiple organs, but we need to be patient-centric in our management. And I'll end my summary here. Thank you.
Can I add a sixth point to your 5-point formula, Panchsheel here? Yes. Can I add the sixth one? Start as early as possible, the day you are born.